Good evening, ladies and gentlemen. It's Matt from ProMed here. Just let you know that you are all in the correct place if you think you're here for the triage process at major incidents webinar. While you're waiting, if you'd just like to introduce yourself in the chat, let us know who you are, where you're from, what kind of background you've got clinically and operationally, and if you'd like to share your LinkedIn, Twitter, Facebook, or Instagram details so we can all stay connected after the webinar, that would be fantastic. I'll be back on just before 7 o'clock to start this evening's show. Good evening, ladies and gentlemen. We're just going to be starting the webinar on the triage process at major incidents shortly. We've just got a few more people in the waiting room who we're going to be letting in. While we're doing that, we're just going to be popping a quick poll on screen just to get a little bit of background from everybody, find out where in the country you're joining us from, or indeed where in the world. Just want to know a little bit about your clinical background and also if you have any experience at using triage before, just so we know what level of course we need to be pitching tonight. Just going to be quiet for another couple of minutes and then we'll get started. Okay, thanks everybody who's telling us where they're from so far. I can see a lot of people coming from the East Midlands and East of England. See a lot of sort of first responders, emergency medical technicians, paramedics in with us tonight. And I can see that around about 42% of you so far have used a formal triage system at some kind of multiple casualty incident. Less so of you have used it at a major incident, but that's absolutely fine. The hope, obviously, is that we don't have to use this, but that's why we do the CPD, because we always need to be prepared for it. Just got another two people we're going to let in, and we're going to start tonight's webinar. So if we can just end that polling there, my admin team, thank you very much tonight for their very generous help in running our webinar. So my name is Matt Dinnery, and I am a biomedical sciences graduate. I'm a qualified teacher with PGCE. I have done MIMS training and Smart DNet training, and I've worked on a variety of events in security, crowd management, medical, and event control and event safety roles since about 2006. And I've worked on events from sort of 50 up to 280,000 guests. So I do obviously do a lot of kind of preparation on a regular basis for those. Just before we get started, this is a free webinar, so we're just going to let you know about some things we do have coming up. So we do have some training courses starting very soon. If you visit promed999.co.uk/training, you'll be able to see the full details and dates of those. But just to give you the highlights, we have a level 3 FREC course, which starts on the 29th of August, running over 3 weekends. We've got a FREC 4 course starting on the 8th of August, which again runs over 3 weekends, but they're spaced out to give you plenty of time to do the workbooks. We have a level 4 immediate life support course, which is good for anyone with FREC 4 healthcare professionals who need to maintain that. That is the 20th of September, and there's also a safe administration of a life-saving medication. If you've got your FREC 4 and you work for a CQC company, that will be on the 26th of September. Everybody attending ProMed's training events have the right to expect a space safe from bullying, intimidation, harassment. You've got the right to be treated with dignity, respect, courtesy, and not be discriminated against. We do have a full code of conduct, which is published on our website. If you do need to report any inappropriate behaviours, if you could privately message ProMed admin team, they will take a look at that straight away. You can also email webinars@promed999.co.uk following the meeting. I'm sure as a bunch of adult professionals, we can all conduct ourselves professionally and appropriately. I do expect that people will have differences of opinion as we go through the slides. Again, that's absolutely fine. We are all professionals. As long as we have those disagreements and discussions in a professional manner, that's absolutely great, because then we can all be learning from each other. If just excuse me for one moment, I just need to sneeze. Okay, and I'm back in the room there. So tonight we're looking at the triage process. So we're going to be looking at various different aspects of that triage process, which includes the triage sieve, the trauma revised triage score, labeling of casualties, and then how we determine the priorities for extricating, and treating those casualties and ultimately evacuating them off to hospital, where the hospital staff will be doing an amazing job, I'm sure. If you'd like to download the slides that accompany tonight's webinar, ProMed admin team is going to paste the link into the chat for you all. Please feel free to download the slides. They do come with all the notes that I am using tonight. So if there is anything you miss or you want a little bit more detail on, they are there. There's also a reference list on the last slides with the original journal articles and any books that I've been using in the preparation of this. I'm sure many of you will want to do your own reading around the subject as well. So first of all, we're going to be looking at methane. And I'm just going to throw a quick poll up. We're going to be asking, first of all, what is methane used for? And there's another question on there as well. I want to know which tool we would use for briefing staff at an incident. So if you've got somebody coming to you who is going to help you out with triage, what tool would you use in terms of briefing them? So I've just popped that poll live now. I'm just going to give you about 30 seconds or so, just really quickly, if you just answer those questions. If you were in last week's webinar, you should know the answer to both of those questions, or if you've got some experience in this sector, you might well remember some of them. Okay, I can see more than half of you have voted there now, and I can see a range of answers for one of the questions. I can see a lot of people for one of the questions seem to be absolutely bang on. So methane is indeed used for providing a report to the control room. Well done, 95% of you. And the tool that we use for briefing staff at an incident, 49% of you correctly selected IIMARCH. And we're going to quickly run through both of those because they are an important part of the overall process, and what we do in triage is affects one of them and the other one affects it. So methane, first of all, would be we're declaring a major incident, or we're going on major incident standby, or we're doing something along that lines. It's optional because we might use it for a significant incident or a critical incident. So whilst they're not meeting the definition of a major incident, it is still the format we would use to pass the rest of the message. So we then need to make sure that we know our exact location. So if we use what 3 words, that's quite common in emergency services control room, and a lot of event medical providers, including ProMed and several others, are now starting to use what 3 words for that interoperability. That's where the incident is. Then we give the type of incident. So needs to just be quite vague. What is in front of us? Do we have a crowd collapse? Do we have a road traffic collision? Do we have an explosion? Do we have marauding terrorists? Do we have some kind of structural collapse? Just a brief overview so people in the control room can start imagining what we've got. We then need to talk about the hazards that are presented and suspected. We need to know what we know is there. We need to take a reasonably good guess at that as well. The access, so what safe routes do we have in, where we're going to be meeting our incoming crews. And then this is what triage feeds into, the number, type and severity of casualties. So your very first methane report, which might even be from the windscreen of your cab before you even get out, isn't going to have this information. But once you get a triage system underway and you gather that number, type and severity of casualties, what you'll be doing is you'll be feeding back with the full methane report, because some other areas within this may have also been updated. Lastly, we're going to go through the emergency services present and required. All of this is available on the Jessup app, which a link will magically appear in your chat for very soon. If you haven't downloaded the Jessup app, we strongly do recommend that you do. And of course, one thing to remember is if you are the first on scene, the easiest way to not get dragged into anything is not to get out of your vehicle or not to walk any closer to the scene, but ring through a windscreen report and then ring back in 5 minutes once you've been able to gather more of this information. So the next tool that we use is what we call IIMARCH. Now, IIMARCH is what we use for briefing everybody. So if we've got a handful of staff who've been sent to us as the primary triage officer, and we need to tell them what they're doing, we need to give them a little bit of background about what the incident is. So the first thing is the information. So where are we? What are we doing? Basically, the key salient points from that methane report. We're then going to go through our intent. So why, the strategy, the tactics, the operations. So the intent is we're going to gather as much information about these casualties because we want to treat them effectively and keep as many of them alive as possible. Then we're going to go through the methods. So this is our how, this is our plan. So we're going to go, here is your triage pack. We are going to say, what I would like you to do is use this piece of paper, follow this algorithm, put this label on the patient, or put the, use a Sharpie and write on the patient, whatever our method is at that time. We'll explain that nice and clearly so that they understand that. The administration, so how we want them to log what they're doing, who they need to report to, where their welfare facilities are, if they need to, if they come across something traumatic and they need that 5 minutes. Risk assessment. So again, back to our methane there, what hazards do we have? What threats there are? If they're going into an incident, do they need to be wearing any particular PPE? Should they be wearing safety footwear? Do they need their helmet? Do we need them to wear high vis so we can spot who the rescuers are? Communications, so if they're using radios or if we're using any kind of shared communication platform, how they're identifying themselves, who they need to be reporting to, if it's a phone system, what is the number that they need to be ringing. And then humanitarian issues is partially to do with them, partially to do with their casualties. And more importantly, in our world, it's about that disclosure. It's about making sure that we keep everything confidential. And obviously, we're not going to be disrespecting anybody's dignity by talking to media or other persons who aren't necessarily authorized. And again, if you've downloaded the Jessup app, that is something else that's available. Now we've done that, we've got people ready to do triage. So you're my triage team. We're going to start triaging. So I just want to know, a quick poll coming up. What is the first thing that we need to be doing? So which comes first? Is it the triage sort? Is it the treatment of casualties? Is it the triage sieve? Or is it the transport of casualties? Those of you who were in our webinar last week might well remember this. If you've done your MIMS course or if you've been on a NARU course, I'm sure this will be familiar territory for you. I can see more than half of you have voted there. We've just got about a third of you still to vote. You can see some really good answers here. You can see everybody has chosen one of the two triages, which is absolutely excellent. I'm really glad that we are starting with triage before we do any kind of treatment or transportation. So well done. We're just going to stop that polling there. You can see there's obviously quite a few people who are not as familiar with triage as some of the others, and that's absolutely fine as well. So 54% of you said triage sieve, and indeed in this scenario, it would be the triage sieve that we are doing. And the triage sieve is our primary triage. So if you look on your screen on our slide there, we've got the triage algorithm. Now, I'm sure this is something that many of you are familiar with. It is available in JRCalc, and it does crop up in some of the major incident kind of grab bags that I'm sure if some of you are used to working on larger events have seen. So we're just going to step through this. So first of all, as you lay eyes on that patient, can you see a catastrophic hemorrhage? Now, we're talking catastrophic hemorrhage in the FREC sense, in the paramedic sense. Can we see blood absolutely hosing out of them? We don't mean a bit of moderate bleeding. We don't mean, an abdominal wound that's got a bit of blood coming out of it. We don't mean a knife wound that's got, a trickle of blood. What we mean in this kind of case is we mean blood spurting. Blood absolutely hosing out onto the floor. It's got to be like arterial, it's going to be venous. These are the kind of catastrophic hemorrhages that we treat immediately, no matter which protocol we happen to be following, whether we're marching, whether we're doing our CABCDDE approach, or whether we're doing triage. The first thing we do is we address that catastrophic hemorrhage, because if we don't, we're not actually going to get very much further down our protocol. So if it's on a limb, if it's something we can get a tourniquet on, that's what we're going to do. If it's something on our body within that kind of trunk, have we got a hemostatic dressing? Have we just got a trauma bandage? Anything we can use to compress and reduce that hemorrhage down to a more manageable level. If we have to do that, then very clearly they are priority one, because all we're doing is kind of very quickly putting a bung in the hole. That doesn't mean to say that pressure isn't going to increase and that bung is going to come flying back out. So let's say they don't have any catastrophic hemorrhage then. They're walking towards us and they look perfectly healthy. We can't see any blood on them. All four limbs are moving purposely. They're blinking. They're able to talk. They might be a bit screamy because they've just been in a really bad incident. But if they're not actually injured, they need to go off to the Survivor Reception Centre. The Survivor Reception Centre will initially be the responsibility of the police, and they will very quickly be handing it over to the local authority. So if you're the first person on scene and you're requesting your emergency services, something you might want to add in is you want a local authority liaison officer, because you want somebody who will take care of managing that Survivor Reception Centre, taking the pressure off the police. They will deal with making sure all those people are taken care of and logged. We don't need to worry about them. They're being sent somewhere. We've now got our injured patient. And this patient is still somebody who's walking towards us. So really quick and easy for triage if they're walking towards us, but we can see in some way, shape or form that they're injured. So they might be clutching their arm, they might be clutching their chest like they're going to have a heart attack. They might have blood oozing from their head. They may have some kind of gross deformity. But the simple fact is, at this point in time, they are walking. So we can hand them a pre-folded P3 tag. There you go, take that, go and wait over there. That's going to be where we're going to be putting our P3s. Just get them grouped together. They've got a tag. We've marked on our tally that we have a P3. That's as far as we need to go with that person right now. So as we move our way further into the scene, the likely thing we're going to be seeing is people who are not walking. Perhaps these people are going to be unconscious. So if they are, we're going to first of all be looking, and we're going to be looking at their airway. As with any patient, whether we're marching or whether we're doing our Dr. ABC or any other variation, airway is nice and high up in that, and we're going to be opening the airway. And that usual 10 seconds, are they breathing normally? If they're not breathing normally, unfortunately in triage sieve, we consider them to be dead. They might well be taking their last gasps, they might have just had an arrest, but actually we simply don't have the volume of trained resources to manage that patient, whereas there are a lot of P1s that we could manage and save the lives of. So if we open their airway and it's not normal breathing, they're dead. We then look and if they're conscious or not. So if they're conscious, we will put them in the recovery position because that's really quick, simple to do. I'm sure most of us can do that within about 10 to 15 seconds per patient. If we're really quick, hand, arm, leg over, there we go, red tag, priority 1. If they're unconscious, they clearly need a little bit more investigation as to why they're unconscious. Might revise that priority later on in the incident, but right now, they're priority 1 for an investigation. So if they're not unconscious and they're looking at us, they're talking to us perhaps, or they're hyperventilating, whatever it is, we're going to be assessing their respite rate. And again, this is a very crude one. We don't need to be standing there looking at them for a minute with our watch going 1, 2, 3, because actually all we're doing is wasting time when we could be assessing. We know what 10 to 30 looks like. The majority of patients we treat day in, day out have a respite rate of 10 to 30. I'm sure as I'm looking at most of you now, your respite rate is probably 12, 14 or 16. It's always an even number because we never count long enough. I'm sure you all agree with that. But we all know what 10 to 30 looks like. Maybe at the lower end, we might want to just quickly count for 10 seconds. Likewise at the higher end, just remember 30 divided by 6 will be 5, 10 divided by 6 will be around about 2. So if you can, 10 seconds, am I getting between 2 and 5 resps? Yes, okay, good. No, okay, red tag. We're then going to look at the circulation and cap refill. So if their respite rate is good and normal, we're then just going to have a little look. We can either do a pulse or we can do a cap refill, whichever's quick and easy. Personally, I would always say the cap refill, just squeeze that finger there or press on the forehead there, or if the sternum's free, press on that sternum. Pressing for up to 5 seconds there, getting nice and blanched, and then we're just going to wait. And that return, less than 2 seconds. There you go, it's priority 2. If that's taken more than 2 seconds, then obviously something hemodynamically is not quite right. Perhaps there's a cardiovascular issue, perhaps there's a bleed that we've not noticed quite yet. But they're priority 1 because we need to figure out what's going on. So the key thing with triage sieve here is that every person involved in the incident in some way, shape or form is going to be getting a tag. So they're either going to be getting a survivor tag and sent to the Survivor Reception Centre or the police and the local authority. If their airway is open but they don't breathe, they'll get a dead tag. And if they are any other definition, they are going to get some form of triage tag, which is going to be altered, depending on the system you're using, to determine that patient's priority. So we're either going to tear stuff off the bottom, or we're going to fold it in a certain way, and we're going to make that person the priority we want them. That tag then stays with them for the life of the major incident. And that labeling is absolutely vital, because from the moment we put that label on them, they've been accounted for in our incident, and that will follow them right the way through till when they're discharged from hospital. So we're going to be keeping a tally, and we're going to be reporting regularly. So your responsibility as somebody conducting that triage is to make a regular report back to the primary triage officer, who is going to take everybody's reports. Now, depending on the system you're using, some of the bags that you will use will have a fixed number of tags, and they will have a tally card. So as you go, you just use a Sharpie or marker or whatever happens to be in the bag ready for this purpose, and you'll just mark off as you go how many P1s, 2s, 3s, deads, and survivors you've given the tag to. You'll hand that in to the primary triage officer, and then they will keep a running total of everybody who's being triaged. Obviously, if you come across somebody who already has a tag, you don't then re-triage them and give them a new tag, because they've already been counted for, and we don't want any duplication. Anytime that we do an intervention, whether that's on scene, whether that is in the casualty clearing station or otherwise, we need to be re-triaging. And if you were here last week, you'll have heard me saying that this particular system isn't suitable for large numbers of pediatric patients without any modification. So if we do have a large number of pediatric patients, what we're going to do is we're going to get our pediatric triage tape out. We are going to start from the head. There's usually a printed head. We're going to hold it there, or get somebody else to hold it, or stick the child's head on it. We're going to roll it out, and where their feet are, we're going to read out those values, and we're going to follow the algorithm within that part of the triage tape, because as I'm sure many of you are aware, if you've done your FREC 4, if you're a paramedic, doctor, nurse, etc., you'll be aware that children have higher physiological parameters for breathing and respirate, and usually a correspondingly lower blood pressure than an adult. So if we were to triage using adult parameters, we'd end up over triaging them, quite often getting them into the priority 1 category when they are more realistically a priority 2. If, on the other hand, we only have sort of 3 or 4 pediatric patients and 50, 60 adult patients, is it necessarily a bad thing we're considering them priority 1 and wanting them to get them away from the scene? Probably not, because although this is purely looking at the physical trauma somebody suffered, we do have to remember the psychological trauma, and obviously it does affect adults, but it's certainly adverse child experiences when those children haven't necessarily got the resilience and those coping skills that we as adults would have. It does have a much more prolonged and long-lasting effect. So we're just going to see how well you can follow this algorithm. So we're just going to throw up 3 questions, and when they come up, I will read them out, and you can answer them one by one, and then submit your answers, and we'll see how people are doing so far tonight. So question 1 is a 9-year-old female casualty who was found lying on the ground, and she doesn't stop breathing when you open her airway. So is she a priority 1, 2, 3, expectant, or dead patient? Question 2, our second casualty, is a 27-year-old male. He runs out of the scene and he's holding something eviscerated from his abdomen. There's a bit of moderate bleeding going on. Is he a priority 1, 2, 3, expectant, or dead? And our third patient is a 56-year-old female trapped under a steel beam with a normal respiration rate and a prolonged capillary refill. I'm going to give everybody 1 minute just to use the primary triage sieve algorithm, which is on the slide, to determine the priority of those casualties. So remember, any catastrophic hemorrhages are priority 1. Anybody who's walking is a priority 3. If you open their airway and they don't breathe, they're dead. And if their respirate is normal and their cap refill is less than 2 seconds, they're priority 2. Otherwise, you would make them a priority 1. So just going to give you about another 45 seconds on that. Okay, we've got a fantastic response rate there, 70% of you. I am aware that Zoom is playing us a curveball tonight, and not everybody's able to see the poll. I do apologise for that. We will report to Zoom. If you wouldn't mind just messaging ProMed admin team if you're not able to see our poll, and could you just let us know if you're using Windows, a Mac, Apple phone, Android phone, whatever you're using, just so when we report that to Zoom, we can give them some fantastic technical information. So we're just going to be stopping that poll there. Our 9-year-old female does not have a catastrophic hemorrhage. As far as we're concerned, she's injured because she's lying on the ground. She's not walking. We open her airway and she's not breathing. So that would take us to dead. Our second patient is running out of the scene. So we can see that he doesn't have a catastrophic hemorrhage. He is injured and he is walking, so he is a priority 3. Well done, 63% of you. However, I can understand why some people may have considered that catastrophic hemorrhage, perhaps. I'm not too sure why we've managed to get them down to a priority 2, though, because if they're walking, they are a priority 3. It doesn't matter what we think of the injury, it doesn't matter what we normally do in our normal day-to-day life. On this triage system, they are a priority 3 because they walk. Our 56-year-old female is trapped, so she's injured, she's not walking. Got a normal respirate and prolonged cap refill, so we're going to assume that she's conscious because we've not told you otherwise. So we said a normal respirate, so we look at the cap refill, prolonged, that makes us a priority 1. Well done there to 65% of you. For those of you who've perhaps not quite got them right, please do watch this back on YouTube later this week, or if you search on the NARU website, you will find this triage sieve. Download yourself a copy and just test yourself, and it's always a good way to stay up to date. So our next thing, before we go into the triage revised trauma score, is the Glasgow coma scale. So the Glasgow coma scale is something that was created back in 1974, and it was amended ever so slightly in 1976 with the addition of another category. So Glasgow coma scale, I'm sure some of you will be intimately familiar with. I'm sure some of you have heard of it and perhaps know what 15 and 3 mean. And I'm sure some of you are kind of all right with it, but probably use the app or use our pocketbooks to remind us what they mean. So the Glasgow coma scale is made up of 3 separate scales. So we have a scale for the eyes, we have a scale for verbal, and we have a scale for motor. So if we start with the eyes, spontaneous eye opening is given a score of 4. So if you look at somebody and their eyes are already opening for you, then that's a 4. If their eyes open to sound, so if I'm looking and I go, Phil, wake up, and Phil opens his eyes, then his eyes are opening to sound and he will be given a score of 3. If, however, Jane doesn't do that and I just gently brush her eyes there and her eyelids start to flicker, or if I just do a little bit of supraorbital pressure and her eyes open, then that's kind of a pressure score that will give her a 2. And if they don't open at all, then her eyes are not responding, so we give a score of 1. The verbal scale goes from 5 down over. So if they're oriented, so if I say, Andy, can you tell me what today's date is? And he tells me that it's Thursday, the 16th of July. And I ask him who the Prime Minister goes, and he goes, I don't know, some really weird guy with some blonde hair. Then he's absolutely oriented. I'm not going to expect any better than that. If I ask him, John, what's today's date? And he goes, it's January. Well, he's a bit confused, so that's not great. If, however, they're not really giving me any full sentences and they're just kind of giving words that don't really make any sense, then we give that a score of 3. If they're just groaning and making some noises, then that's a score of 2. And if we don't get anything verbal at all, then that is a 1. And lastly, our motor, and this was adjusted in 1976 to have a little addition put into it, so it's now a score of 6. So if we obey commands, that's a 6. So if I say, Mick, can you raise your right arm for me? And he raises his right arm, then he's obeying my command. If I say, Mick, open your, squeeze my fingers, and he doesn't, okay. But if I squeeze his finger and he kind of tries to pull his finger in, points to his finger, localizing that pain there, that's a score of 5. If we get normal flexion, so if I squeeze down on your fingertip and you just pull that away, that's normal flexion, that's a withdrawal response from pain. Likewise, if I do a BM and I can feel that little kind of withdrawal, that's normal flexion. Motor is abnormal flexion, so that's flexion in the wrong direction. That's given a score of 3. Extension, that's even worse. So if I'm squeezing your finger and you're pushing your finger towards me, that's an extension, and we don't want to be seeing that. That's a score of 2. And lastly, of course, if we don't get any motor response, then that's a score of 1. Now, just to be absolutely clear on motor response, we are not applying knuckles to sternums. We are not doing anything that will be regarded as torture. We are not doing anything in any way, shape, or form that is genuinely painful. We are applying pressure to see if they can localize that, if they pull away from it, if they pull away from it in the wrong direction, if they move their appendage towards that, or if they don't respond. If they don't respond, we do not inflict more pain because we already know they don't respond and we don't need to do anything more than that. So now I've gone through that, I'm just going to throw up another poll just to check your understanding of the Glasgow coma scale. So we've got 3 more random patients for you. And what I want to know is I want to know their scores, their eyes, verbal and motor scores. So our first patient is presenting with spontaneous eye opening. They're oriented and they're obeying their commands. So what is their Glasgow coma scale? Our second patient presents with closed eyes, but their eyelids do flutter when we apply a little bit of pressure supraorbitally there, and they speak random words and they're able to localize the pain. So what's their GCS? And patient number 3 is presenting with their eyes closed, but which open when you call their name. They come across a little bit confused and they can localize their pain. So what would their GCS be? I'm just going to give you about 45 seconds to do that. Okay, I can see a lot of people have had a little bit of thinking time and are starting to come up with their answers now, which is great. Just over half of you there. So just going to give you about another 20 seconds for everybody else to catch up. Okay, so let's take a look at patient number 1. So patient number 1 has spontaneous eye opening, which gets a score of 4 on the eyes. They are orientated, which gives a score of 5 on the verbal, and they obey commands, which gets a score of 6 on the motor. So all 100% of you there got that right. Our second patient presents with closed eyes, but their eyelids flutter when pressure is applied. So that would be an eye score of 2. They speak random words, so that is a verbal score of 3. And they can localize their pain, which is a motor score of 5. So we have E2, V3, M5. 87% of you got that correct. Well done. And our third patient was presenting with their eyes closed, but which opened when we called their name. So that was to sound. So that's an E3. Their verbal score was that they were confused, so that is 4. And on motor, they were localizing pain, which was 5. So E3, V4, M5, 92% of you got that right. Absolutely well done. You're going to need this as we go on to the Triage Revised Trauma Score. So the Triage Revised Trauma Score, we've just put that up there. But I want to know, before we get into it into too much detail, who do you think is actually able to use this reliably? So just another quick question coming up there. Who do you think can use our Triage Revised Trauma Score and apply it consistently? So is it only experienced healthcare staff after a briefing? Is it any emergency services personnel if they are trained? Is it willing volunteers if they've had a simple briefing? Or is it only the ambulance service staff with specific training? Okay, that's 3/4 of you voted. Well done. I'm just going to get those results shared because I think they're quite interesting there. What I've noticed is a lot of people have gone for any emergency services personnel if they are trained. So you can just see those results there in a second. Let me hit the button for you. So there you go. 57% of you went with that. 15% of you think only experienced healthcare staff after a briefing. 13% believe any willing volunteer after a simple briefing. And 15% believe that ambulance staff with specific training are able to use this. The Triage Revised Trauma Score is based on the respiratory rate. Granted, a lot of people would be able to do that, but actually how many people are able to do that without influencing the rest rate by saying to a patient, I'm just going to count your breathing. You and I know, if we've done this in practice, that you go to a patient, I'm just going to count your rests. I just need you to be quiet. First thing you start doing is can you hear me breathing okay? Yeah. Yeah, so you've got that false respirate situation going on there. Now, systolic blood pressure, we've got some absolutely fantastic automated devices. Don't always work in a very noisy kind of major incident environment. They can easily be affected by a lot of things. And the Glasgow coma scale, all of you guys were almost absolutely bang on, over 90% on every question. But you did have that reference sheet in front of you. I'm sure many of you are experienced in using it. But how many sort of non-professionals will be able to use that, do you think? So the answer that I've asked for, the answer that I was aiming for here was only experienced healthcare staff after a briefing. An experienced healthcare staff doesn't have to be a healthcare professional. It doesn't have to be somebody working in the NHS or the ambulance service. It could be somebody who's experienced on events and does a lot of OBS all the time. It could be a healthcare assistant who does OBS in a neurological unit. It could be anybody in healthcare. If they are confident and competent at obtaining a respiratory rate, preferably manually taking a systolic blood pressure and being able to work out the Glasgow coma score, then after a briefing of how to use that data to calculate the score, they'll be able to do that. I think the other groups of people, I think with the best will in the world, I think emergency services personnel, I think there's a lot of kind of police and fire who would give it their best shot, but wouldn't necessarily have the level of experience needed to do this reliably. And I think willing volunteers, unless they fit into that group of experienced healthcare staff who happen to be there anyway, just won't have the understanding of the equipment that we're going to be using to do that. Absolutely, ambulance staff with specific training, they fall within our kind of overall remit there of experienced healthcare staff after a briefing, I would say. So a total score of less than or equal to 3 is the expectant category if the expectant category has been invoked by our very, very, very strategic command levels. A total score of 0, as you can imagine, with a respiratory rate of 0, a systolic blood pressure of 0, and a GCS of 3 means the patient is dead. So we're absolutely going to be applying this on arrival to the CCS. So when the patient arrives at the casualty clearing station, we've got a lot more time on our hands. We've got more personnel available to carry this out, and that's going to determine where in the CCS we're going to be sending them. Once we're inside the casualty clearing station and they perhaps had a little bit of initial treatment, and the medics and the nurses and some of the specialist paramedics and other specialist teams are there, they might supplement that with some anatomical information. And we're going to look into that in a little bit more detail as we go through the webinar. And again, we're going to be recalculating this on their departure from the casualty clearing station with any information that is now available to us. So we're just going to look at some casualties in a second. So we're just going to very quickly run through what adult triage short is. So if their respiratory rate is between 10 and 29, so we're using those same values again, they're going to get a score of 4. If their respiratory rate is too high, their score is 3. If it's between 6 and 9, it's 2. If it's between 1 and 5, it's a 1. And if they have no respiratory effort, it's a 0. So our systolic blood pressure, if it's above 90, so if we can get a radial pulse, then we're going to consider that to be above 90. But ideally, we're going to be measuring that, and ideally, that is going to be done manually. If it's above 90, we're going to give them a 4. If it's between 76 to 89, it's a 3. If it's between 50 and 75, we'll give them a 2. If it's between 1 and 49, we'll give them a 1. And if their systolic blood pressure is unrecordable, they get 0. For their GCS, we just add up all the numbers together. If they come to between 13 and 15, they get a score of 4. Between 9 and 12 is a score of 3. Between 6 and 8 is a score of 2. 4 and 5 is a score of 1. And 3 would get a score of 0. So we add those 3 scores up. So 4, 4, 4 potentially. A total score of 12 is priority 3. If we add them up and we get a total score of 11, so if just any one thing is slightly out, they're a priority 2. And a total score of less than or equal to 10 is a priority 1. So if one thing is seriously deviated, or any 2 things are deviated, they will become a priority 1 on this system. That's the really easy way to remember what priority they are. So first of all, we're going to throw up our casualties, and we're going to look, we're going to calculate the GCS. So we need to remember what we've just been doing. I'm not going to put the GCS back up. We're going to see what stayed in your memory for the last 5 minutes. And we're going to look at patient number 1. Patient number 1 has their eyes closed, but they open when you call out their name. They come across as a bit confused and they're able to localize pain. We measure their blood pressure manually and get 79/52, and we accurately record their respirator of 28. So what is their score? Our second patient has spontaneous eye opening, oriented and obeying commands. Their respiratory rate is 12 and their blood pressure we record manually at 88/63. So what score would we be giving them? And finally, patient number 3 presents with closed eyes, but their eyelids are fluttering when we apply that supraorbital pressure. They speak some random words, but nothing at all that makes sense. They're not stringing a sentence together. They are able to localize pain with a blood pressure of 95/71 when we do that, and their respirator is 9. So what would be their score? So we're just going to give everybody about a minute, maybe a little bit longer. This one does require a little bit thinking, especially remembering what was on the last slide. But have a go, have a guess, and we shall review them in about a minute's time. Okay, do apologise for that. I've just realised I didn't unmute myself before I went through that. So what we were doing there, we just talked through the first patient. So we calculated their GCS, which was eyes 3, verbal 4, and motor 5, giving us 12. The systolic blood pressure being the number on the top, 79 is between 76 and 89, and the rest rate of 28 is between 10 and 29. So that gave us our score of 3. Add 3 is 6, add 4 is 10, which is then priority 1. So now I'm talking through, and we're going to do this live, and I'm not going to look so silly this time. Our second patient is presenting with spontaneous eye opening, so that's 4. For the eyes, they're oriented, so that is a 5 for the verbal, and they're obeying commands, which is a 6 for the motor. So that's a GCS of 15, which gives us a score of 4 there. Their rest rate is 12, so 12 is again between 10 and 29, so that's a 4. And their blood pressure is 88/63, systolic, that big number on the top. So 88 is again between 76 and 89. So if I do 4, add 3 is 7, add 4 again, that comes to 11. And lastly, our third patient, I'll just change the colour of the pen again there for you. So our third patient presents with closed eyes, but their eyelids flutter when pressure is applied, so that's E2. They speak random words, so that's a V3, and they can localise pain, which is an M5. So that's 2, add 3 is 5, add 5 again is 10. So a GCS of 10, that sits there between 9 and 12, giving us a score of 3. Their blood pressure is 95/71, so their systolic blood pressure is above 90 there. And their rest rate is 9, so that's our 6 to 9, which is our 2. So 3 and 4 is 7. Add the 2 is 9, so they are less than 10 there. So there we go. So just going to stop polling now. Well done to 2/3 of you who had a go. Question 1, 46% of you answered correctly. Question 2, 66% of you got that right. And question 3, I can see that 57% of you got that correct. So that is absolutely fantastic. We're just going to turn annotations off so we can move on. Now we're going to start looking at the labeling. We're just going to clear the slides there. That's better. So we're going to start looking at the different labels now. So some of you may have come across 1 or 2 of these. Some of you may not have come across any of these. The first one we're going to look at is what is called the METHANE system. And this is something that is quite heavily used in the United States of America. And the way it works is every patient gets one of these labels. There are different types, as you can clearly see there. And the perforated lines, so those dotted lines at the bottom, they're perforations, and you tear off. So if they are a P1, you would tear away and throw away the P2, P3 tags. You can quickly write on any information that you know, so male, female, where they live, name, time and date. They've got little diagonal perforations at the top there. So when you leave the site, you would tear that off and give that to the ambulance loading officer so that they would be able to make a note of where that patient's gone. Then when you get to your destination again, you tear that next bit off and they can use that to book that patient in. They have barcodes on the tags, which obviously match those 2 labels, so that helps with your patient tracking. However, it's very easy. If I give you a full tag, but you're sick of waiting, how easy would it be for you just to tear off a tag and make that green bit disappear? I'm sure you can kind of realize that the third version is rather deliberately done the other way around. Because if green's at the bottom, our patients might well choose to do something themselves. So there's standard graphic symbols. So these particular tags are very graphical. They don't use very many words, and that allows anybody to be able to apply this triage system regardless of any language or cultural or literacy barriers. They are able to use this in the field, even under pressure, because they can kind of work out what the symbols mean. We all know, obviously, that dagger is death. The hare is obviously faster than the tortoise, and the ambulance symbol with a red line through it means they don't need an ambulance. These particular tags, they look like cardboard, but they're a high density, damage resistant synthetic material, and it's used a thermal printing process, so it's not going to get washed off easily. It's got a 30-inch elastic band, so you can attach that to an available limb or around the neck or anywhere else if you make it a bit tighter if you need to. and then they are adapted and they are filled in as you go. As you can see from the middle one there, you've got a little area for time and intervention, so what you're doing. There's also an observations chart available on them. The third version has information for medication and allergies, so you could even have patients filling that out. The other thing with that third one there, this is the American version of the triage protocol, not the one we've just taught you. But very easily, you just tick why you've gave them an immediate category, or otherwise, delayed if you haven't already picked one of the first two. So that just means you don't have to have any kind of additional prompting to use their particular triage protocol there. Absolutely right, Mick. Yep, you hand it out to the P3 and they fill it in by them. That's exactly what the idea is. If the patient is capable of filling it out, why do we need to be wasting our time? So our next system we're going to be looking at is the cruciform triage system. This used to be used quite a bit in the UK. It still is in certain sectors. Certain private industries that are likely to have large numbers of patients might well have this system. It is slightly cheaper than SMART, and it is readily available. So it comes in a box. And it's ready to use in a box, but it is a plain cardboard box. So I'm sure you're all already thinking of, great in a shopping centre, but what about outdoors in a muddy field? Is the box going to survive even if we don't have an incident? It's got a lot of barcoding, and you get a free wristband with every patient. So as well as giving them a tag, you can also give them a wristband which has the barcode on, meaning that if anything gets separated, you can still positively identify which patient it belongs to, which is obviously fantastic. It's great for sitting and sorting, and you have lots of spare barcodes as well, so you can attach them to records, you can attach them to the patient's personal possessions, or if the unfortunate patient is in several parts, if they've had any amputations or otherwise, you can attach labels to them and kind of make that reconciliation process a lot easier. You could also, somewhere on the form is a marker for relatives, so you can kind of cross those barcodes over to ensure that relatives are easily to be traced up on. You get boxes, they typically come in boxes of 25, and if you look at the middle sort of screen image, that middle image there is the priority. So you would take a barcode from the patient sheet, attach that to your master kind of thing, and then you would tick, circle, or otherwise annotate which priority you've given them. So in terms of adding up your numbers, you can actually see much quicker how many patients you've got, but in terms of working out that breakdown of priorities, you're having to do a little bit more mental arithmetic to get those figures individually. They do come in smaller packs of 10 for lower risk things, or for where you think you might have a multiple casualty scenario, but you're not going to get into those kind of mass casualty or true major incidents. And it does have other supporting documentation, and indeed the cruciform national PRF has a space for those barcodes as well. The third system that we're going to be looking at is labeling using the smart triage tag system. This is quite commonplace. I believe it's now recommended. It's certainly quite prevalent across lots of our UK ambulance services. It has a simple folded design. So like the cruciform is based on a cross shape. The smart is based on an extended Z configuration. So you can reprioritize your casualties just as easily on cruciform or on smart, just by refolding that. Again, vulnerable to patients refolding that, no doubt, but we can always refold that back. It's designed to survive the worst conditions, so it is a durable sort of, not quite waterproof, but water resistant, hence why it comes in a plastic little bag to keep them in. And it's quite big and easy. It is larger than the cruciform tags, so it is quite easy to see. And if you buy their sort of triage packs of 20, you also get light sticks in red, in yellow to identify where your casualties are. Those bags, so the smaller bags, which are the ones that are kind of on the outer part of the bag on the right there, they have a belt loop, and it's really easy to kind of just clip that onto your belt. Worryingly, I have seen people walking around with them on low risk events. That's by the by. But you can also, clip them to the front door of your first aid post. You can have them available just inside the back door of your ambulance. It's really easy. It's not like a box that you need to keep stored away. It's not like a pile of loose tags that are going to slide everywhere. They have designed that quite well. And then the bag itself, is designed for commanders, so it comes with a clipboard and that overall tallying, so everybody hands their tags back to you, and you've got a surface where you can collect that information, and it just lets you set up ready to rock and roll. In the middle there is the smart version of the triage tape. So now we've gone through those systems, I'm just going to go back to our Triage revised trauma score, and I'm just going to very quickly launch our next poll, because we just want to see how much you remembered from 5 minutes ago. And we've got some patients now with a full set of observations. So this is in our casualty clearing station, and we are assessing these patients. So patient number 1 is in the casualty clearing station walking around. I asked them to sit down. You take their heart rate of 88, rest rate of 16. BP is 122/78 with a cap refill of less than 2 seconds. Their GCS comes out as E4V5M6. They've got a clear airway and no signs of a catastrophic hemorrhage. So what's their secondary triage priority? Is it 1, 2, 3 or dead? Patient number 2 is being assessed. They're lying on their stretcher in the casualty clearing station. They've got a lower leg fracture, and you note their observations. Got a heart rate of 110 beats per minute, a rest rate of 14 breaths per minute. Blood pressure is 102 systolic over 77 with a cap refill of 3 seconds. Their GCS is eyes 4, verbal 5, motor 6. They have a clear airway and no sign of catastrophic hemorrhage. So what would their secondary triage priority be? Patient number 3 is assessed as they're being brought into the casualty clearing station by our wonderful water fairy friends. We note their observations of 48 beats per minute when we take their pulse. Rest rate is 8 breaths per minute. Blood pressure is 85/58. Cap refill is prolonged at 4 seconds. GCS we're getting eyes of 2, verbal 3, motor of 5. Got a clear airway and no signs of a catastrophic hemorrhage. So what would their secondary triage priority be? You can see 22% of you got stuck straight in while I've been talking. We're just going to give everybody else another 45 seconds or so to catch up with you. Okay, half of you have done your voting now. We're just going to leave that poll running, and I'm just going to start running through these. So we're doing a secondary triage, which is our triage revised trauma score. And that means we're going to be using this little table on our right. So the values that we care about, first of all, will be the rest rate. So with a rest rate of 16, that's between 10 and 29, giving us a score of 4. The next one we want is the systolic blood pressure. So BP 122, that's above 90. And again, we're going to give them a 4. GCS 4 add 5 is 9. Add the 6 gives us 15. So 13 to 15 gives us a score of 4. 4 add 4 gives us 12. And therefore, they are a priority 3. So if we now move down to, well done, 93% of you there. We're now moving on to patient number 2, who's lying on a stretcher, but we don't really care about that right now. What we want to do is we want to know what their rest rate is. Their rest rate is 14. So again, that's in this area here, and that gives them a score of 4. Systolic blood pressure 102 is also above 90, so that gives them a 4. And the GCS 4, add 5, add 6. 4 add 5 is 9, add 6. There we go. So that also gives us 4 add 4, giving us 12 again. They're also priority 3, 55% of you. Well done. I'm just going to change the color of the pen once more for our third patient. So our third patient, fire crew, well done, thank you very much. What we care about though is what their respirate is. So 8 is between 6 and 9, giving us a score of 2. So you should straight away be able to work out where this is going to go, but we'll run through the motions anyway. Systolic blood pressure of 85. That sits there, which gives us a score of 3. GCS 2, add 3 is 5, add 5 again is 10. So that is between 9 and 12, giving us 3. So 3, add 3 is 6, add 2 is 8. That's a score of less than 10, therefore they are a priority 1. So well done, 86% of you. So I can see a lot of you absolutely are managing to remember everything that I'm saying and be able to apply that in a real context. Which is absolutely fantastic. So we're just going to clear those drawings again before I continue. And we're just going to rapidly once more just give you another chance to look at the labeling of these casualties. So labeling being absolutely key when we're triaging, because we don't want to waste time duplicating each other's efforts. So this is our METHANE system, which has the tear-offs at the bottom, but it does include a lot of space for writing. We have our cruciform system, which is a cross-shaped folding system in a cardboard box with lots of barcodes to identify different parts and possessions. And we have our smart triage system, which is our Z fold with commander kind of options available. So when we're deciding what triage system we might want to use, obviously, if we work for the NHS ambulance service, that's not our decision, but this is what NHS evidence would be looking at. If we own an event medical company, or if we're the organizer of a mass gathering event, or perhaps we are responsible for a shopping centre or an arena, and we want to be prepared just in case this happens, we want to think about what is actually important here. What do we want to know? What is going to be the pros and the cons of each system, and how is it going to work in our environment? So first of all, how well does the system keep track of the patient and their possessions, or indeed their body parts? So how are we managing to reconcile all of those together from when we find them at scene to their ultimate discharge from hospital or other setting? How easy is it to change the priority of a patient in each system? So don't just think about needing to re-triage a patient higher, but also, as we've identified through some of them, you also need to re-triage a patient lower. How is that system going to fare up in a cold, wet environment? I'm sure all of the systems in our nice homes right now, where we've got plenty of time, we've got bare hands, we'd have no problem using them. But if it's the middle of winter and it's a snowstorm and everything around us is saturated, the ground's already wet, not only are we perhaps wearing our gloves for clinical reasons, but we might even have kind of warming and protective gloves on. How easy are we going to find this system to use? How can we train somebody to do triage sieve? So we can teach a lay bystander how to triage sieve somebody, because all we need to know is, are they walking? Can you open an airway? Do they breathe? How fast are they breathing? And when you squeeze their finger, does it go red quickly? They're all things that we can teach, anybody with an ounce of common sense. So police and fire are usually very good for this. But they need to remember how to get to priority 1, how to get to priority 3. They're always going to remember dead. They're always going to remember survivor reception centre, and they're always going to remember walking. But actually, hang on, is that priority 1 or priority 2? How do I get there? How easy is it going to be to teach somebody to do that triage sieve using that system? And then the other thought is, what are we using these barcodes for? Does your fleet of event ambulances have a barcode scanner? Do you run a busy sort of first aid post at an event, and do you have barcode scanners? Does your receiving hospital have a barcode scanner? Because actually, if you haven't got a barcode scanner, then you're still manually reconciling numbers. You can buy USB barcode scanners for £20, and actually they are really useful because you could actually set up a really simple Google Sheet and you could use the barcode scanner as a keyboard input. But we'll be looking more into that in our future webinar when we're looking at patient tracking in major incidents. We're not going to waste too much time on that. So what I want to do is I want you to rank the 3 systems we've looked at tonight. Which one is the best? Which one is the worst, and which one is in the middle? Now, I am trusting you to not muck up the scoring. Zoom doesn't allow you to only select one answer for one question, so please don't screw up my scoring. So do you think METHANE, cruciform, or SMART is the best? Which one of those is the worst, and which one would you rank in the middle? And at this point, I strongly suspect I'm going to see how many of you work in NHS ambulance services. And it's fair to say that the results are actually a lot more split than I may have first anticipated. 55% of you voted there, so I'm just going to give you a little bit longer to have an opinion. There's no right or wrong answers, of course. This is just opinion gathering. Think about you as a user. Think about you as somebody managing the process. Think about being that untrained person being told, here's this, I want you to go and do that with it. Okay, so I'm just going to stop the polling now. I'm going to share your results. So it's pretty much safe to say with 73% of you, smart triage tag is the best. 57% of you therefore ranked cruciform as being the middle, and the worst you were saying was METHANE. What's interesting is actually METHANE, although it is clearly the one in the lower half, there were almost as many people saying that is in the middle as cruciform as the worst. So we'll actually analyze those results properly and put a little Excel together before I send out our email to you all for attending this webinar, just so we can kind of see that breakdown. So that's a nice little opinion poll there. So the last thing that we're going to talk about in our triage session is the priorities and how they might change. So first of all, while we're still on scene, initially, they're going to be triage saved, and it is that priority that we're going to use. But we might not necessarily have sufficient resources to extricate all of our casualties, and we might have time to do a more detailed clinical assessment. And if we do, we can start using triage short priorities. There's nothing to stop us doing a triage short, using that TRTS for a casualty that is trapped on scene, because we just can't get them out. And actually, it is a clinically valid thing to be doing. If you're there and you're working with that patient, you're going to be gathering these observations anyway. And if everybody else is getting a triage short assigned to them, then these patients are no less deserving of that level of scrutiny. So at this point, we're going to be using our forward medical teams of doctors and nurses. We're going to be using our forward ambulance teams, and we're going to be getting some clinical input as well. So we're going to be looking at the gross anatomical features. So do we have any amputations? Do we have any trunk injuries? We're going to be looking at the cardiovascular and the hemodynamic stability. So what's that like now? But actually, depending on what's trapping them, if they're trapped by something crushing them, how is that cardiovascular and hemodynamic stability going to change during the release? What is their homeostasis mechanisms doing? What can we do in situ? So if it's cold outside, are we going to be hitting some blankets on them because we don't want them shivering? If it is a hot day, are we going to be maybe giving them some water to drink if they're able to, or are we going to be giving them some fluids if it might be that they could get dehydrated? We're going to be thinking about homeostasis. We're going to be trying to do what we can in situ. And then lastly, we're going to actually be using the expertise of the fire service, because if they are actually trapped by something, or if something is crushing them, then the fire service are the ones who are the experts at removing that. But that structure, and I'm using the term quite loosely because that structure could be part of a lorry, it could be part of a train, it could be a fallen concrete block, who knows what it is. But what else is it affecting? So is that, is that skewer that is going through somebody also trapping 3 other people, and is somebody lying on it on the other side? And the fire service will be kind of using a very holistic approach and looking at that kind of really big picture. So we're looking at the individual casualties priorities, but the fire service are going to bring that holistic argument in terms of the order that they think it's best to release. And that is going to be a joint conversation. So we're going to use that joint decision model from Jessup that we spoke about last week. And, we're going to prioritize and we're going to work on that together. Next up, we're going to be looking at how we're treating our casualties. So as they come through the casualty clearing station, where we provide most of the treatments at major incidents, we're going to be triage sorting them. We're going to decide, are they going to red, yellow, or are we going to be sending them to wherever we're holding greens? And again, we're going to be looking at casualty clearing stations in more detail in another webinar. But in terms of triage, this is where our healthcare professionals who've arrived at the scene or are part of our air ambulance response or a part of our basics response or whatever our local sort of provision is for getting healthcare professionals to scene, whether that is the paid ones in the hospital at that time, or whether that's the ones volunteering it through some other form. And they're going to use their clinical judgment, their clinical experience. They're going to look at gross anatomical features. They're going to look at that cardiovascular system stability. They're going to look at any injuries to the thoracic region that particularly is going to be affecting them. They're going to look at the hemodynamic stability and the homeostasis features, because they might want to upgrade a patient or downgrade a patient based on their experience and judgment of that patient. Because actually in the CCS, we're almost bringing the ED to that scene because we need them to be stable enough for an onward transfer. And then in terms of evacuating those casualties to hospital, so we're going to repeat the TRTS once more, once we've done all the interventions that we're doing to make sure that they are stable and packaged for transport. And again, the experienced clinician who is overseeing patients going through the ambulance loading point, and they might well want to upgrade or downgrade the order that they think patients should be going in. But also at this point, we're going to look at the availability of the transport mode and what qualified personnel we have, because some patients might well, they need to get to hospital fast, and it might be worth them waiting 10 minutes for a helicopter, which will have them at hospital in 10 minutes when the hospital's 30 minutes away by road. But, if they're going in a helicopter, hopefully that's one of our lovely charity air ambulance services, which comes with its onboard doctors and paramedics. If we're kind of cadging the help of the police or the military rescue services, the Coast Guard, then we might need to be looking at, are we going to be providing those doctors and paramedics for those transfers? So DMA, if you don't know the abbreviation, is a dual manned or double manned ambulance. And again, depends on the patient's condition. Do they need a doctor or nurse with them to ensure that they remain stable? Have we started them on a particular set of drugs that is above or outside the scope of those paramedics that are available? Is it actually that we could do with that doctor continuing that particular patient's treatment because they've already explored the wound and there's no point re-exploring it by another clinician? Can that patient go with a paramedic? Can that patient go with a technician? Can we get their relatives into a double-manned ambulance? If they're actually a family of three, could we get all three of them away in one go? That's a factor. Do we have a patient transport vehicle that we can send with a technician or a first responder in the back to look after a group of patients who may well have been P2s when they were first being treated, but actually we've managed to successfully stabilize them and get them into a P3 state. So we do need somebody there that can deal with them if they deteriorate again, but we think they're going to be stable enough for a normal road conditions transfer to maybe that second or third nearest hospital that's going to be dealing with our lower priority casualties. But then through the local authority and our other partners, so whether that could be Transport for London, Transport for Greater Manchester, Northern Rail, Network Rail, whoever it may be, can we use them to assist us? There are certain festivals that do have a contingency for trains in this country because their festival happens to be on the border of a train site which has an access gate. Likewise, I do know of some festivals that, as part of their contingency, have narrowboats and pleasure craft on a canal because their festival site borders that, and that is a way that they know they can move 20 or 30 people in one go to somewhere where they could arrange a second rendezvous point to then transport them by road. So they're all different kind of considerations that we have to have when we're evacuating casualties is how are we getting them to places. And that's the ambulance loading officer who will be making that decision in charge with the casualty clearing officer, usually the sort of medical side. And that wraps up our triage webinar for tonight. So I'm sure many of you, like last week, will want your CPD certificate. So please do email us, webinars@promed999.co.uk. Please do include your full name. And if you are signed into Zoom on a different email address, please include that. Likewise, if your Zoom name is not your real name, please do include that. We do download a registrations report and we do verify that. We will email your digital certificates within 3 business days. So if you get your certificates emailed in tonight, we will probably have them to you on Monday or Tuesday. Quite a lot of our staff are out on events this weekend. It seems to be the first weekend when a lot of event organisers have started up in full. So a lot of our staff are going to be busy. Nonetheless, if we do get the chance, if we do have a little bit of spare time, we will try and send you CPD certificates out a little bit earlier. Once again, just to let you know, the webinar has been provided free of charge by ProMed. We want everybody to be trained in this. We do want everybody to understand what to do if the worst should happen, because by having more people who are competent in doing this, or at least have an awareness of it, we're all able to provide the best possible care to our casualties. And we don't know whether we would come across this in our professional or our personal lives. And this is something that we do genuinely believe everybody should at least have a loose awareness of. So we are absolutely thrilled that sort of 55 of you have stayed for the night. So please do leave us a review because you have benefited from our skills, our knowledge and our expertise this evening. Not just mine, but ProMed admin team have gave their time free of charge tonight to provide the support that some of you have been using this evening. So please do leave us reviews. Trustpilot, Yelp, Google and Facebook are where we are on the platforms. So we're going to open up to question and answer. So if you want to raise your hand using the Zoom raise your hand feature, that's absolutely fine. We'll ask you to unmute yourself and you can speak verbally. I can see a couple of questions coming through on the chat. So while I'm waiting to see if anybody wants to raise their hand, I'm just going to flick up through the chat through earlier in the webinar and just have a little scroll just to see. So we've got Lord Harley, would we recommend triaging children first? No, you basically triage in the same order that you come up to the patient. So if you come across a 90-year-old first, then a 2-year-old, then an 80-year-old, then an 18-year-old, that's the order you came up. You just triage as you come to them. And if they're leaving, then absolutely. So I can see some great ergonomics. Mick Murphy, you're absolutely right. The Glasgow coma scale, it was predominantly generated as a neurological assessment tool, but the authors of the paper have said on their website that it does have applicability for assessing any patients, particularly unconscious patients. Tyrell, can we trick them by taking a manual radial pulse and focusing on their chest rise and fall? Absolutely, that's a technique I was taught, and that is the technique that I teach other people to do. Sometimes I lift that radial pulse. So if I'm doing a radial pulse, I might want to move it across the chest, particularly if it's a male. If it's a female, I might want to move it a bit lower down so that there's no kind of accusations going on there. And I would, yeah. But again, as I was saying, this is something that we know, but not necessarily are kind of helpers from other emergency services. Nikki, yep, radial pulse, we can, for the purposes of triage, we would treat that as a systolic of at least 90, but when things calm down, we would want them to be done correctly. Yes, I was aware of that. Yep, Mick, you can't score a GCS2 or a GCS1. Yes, the absolute minimum score for a GCS is 3. The maximum score is a GCS of 15. And in the middle of that, there is 11 scores, but those 11 scores actually give you 118 possibilities for your eyes, your verbal and your motor score. So if you are using this for your clinical observations, if you are writing this on a patient clinical record or the back of a triage tag, please write down E, V, M and the score, because that information is much more telling than that kind of aggregate score, because as I say, there's roughly 10 different options for every one score. Recent incidents, it seems they've been dividing P1 from P2 or P3 as big sick, not big sick. Yeah, so absolutely. So your P3s on that initial sieve, well, they're just not even sick, let's face it. We're putting them somewhere they can wait. And yeah, our P1s are our big sick. Our P1s, we're laying eyes on them and we kind of know where we're going. We already have our gut feeling. And our P3s are the ones that, yes, we know they need our help, but we're calling them kind of little sick, really. And yeah, Mick, you're absolutely right. We've absolutely got loads. If there's kind of, 2 people able to do triage and you know your backup's 20 minutes away and you're looking at 100 people in front of you, yeah, big sick, little sick, get a 1 and a 2 on, at least you've got a vague number. And then when you get more people in to do your triage, then I'll be sending them in and go, right, everybody's got a triage tag, but the 1s and 2s were just done on an eyeball. Can you actually assess them for me? The 3s are all fine, no. And then you've got more responders, you're able to do that. Alan, yep, a large green marker pen for the forehead, yes. If you see me Generally, in life, I have a Sharpie in my pocket. Absolutely, when I'm doing medical stuff, I usually have 2 or 3 Sharpies somewhere in my pockets. Because if you don't have these wonderful systems, if you don't have, those 50, 60, 70, 80 pound bags that we are all trying to be sold, a humble Sharpie, a good quality permanent marker that isn't just going to rub off easily, that you can write on the forehead, on the back of the hand. Back of hand's not actually good. The best place is actually where my wrist watch strap is. So this side, certainly when I used to be working in nightlife, doing stuff on clubs, if I was stamping people, I would stamp them here because the stamp is a lot less likely to come off here, whereas the back of your hand ends up on all sorts of surfaces and things get rubbed off. Wrist snappers, yes, Mick. There's the ones that you just literally snap on and they go. I've also worked for companies that have got the plastic style popper wristbands in red, yellow, green, white and black, and you would just attach them to a patient. Again, a lot of them can have serial numbers printed on. And again, that's a perfectly good cheap option, but you then still need to be recording your patient details. So just going to casually flick down. You're all very welcome. I'm really pleased you're enjoying that. Really pleased. Thank you very much for everybody. Neil O'Gorman, what is the difference between dead and expectant? So if the incident is absolutely overwhelming the local response, then at a very senior strategic level, and this usually involves the kind of chief medical officer or chief ambulance officer for a particular region, they would make the decision at that level. So, way above ambulance control level. They would say, okay, we are going to invoke the expectant category. So a dead patient is a patient who we know is dead. So we've opened their airway and they're not breathing, or we have TRTS them and their JCS is 3, there's no rests, and there is no recordable systolic blood pressure. An expectant patient is perhaps that JCS of kind of 4 or 5, where we know that from a JCS of 4 or 5, you're only going to end up at JCS 3. At least at JCS 3, you can go up again. JCS 4 or 5, then realistically, you're only going down from that particular point. Or where their blood pressure is so low and you can still see blood coming out of them. Where they're respirate, they're really kind of bragging down. And it's where, even if we threw, 2 doctors, 2 nurses, 2 paramedics at them for half an hour, we maybe only have that 5 or 10% chance of keeping them alive to admission, and an even lower chance of them actually getting a discharge to survival. And it basically, what it's there for is it's there to free up those patients who have been triaged as a priority 1, so they're getting that level of healthcare input, but at the expense of other P1s who have got a much stronger chance of survival, that maybe only need 1 doctor or 1 nurse or 1 paramedic to manage them for that interim period. And it's a kind of, it's almost like a sacrificial decision, and that's why it has to be invoked at a supremely high level in the UK. Tyrell, the previous webinar, we mentioned the term zero responder, how civilians, witnesses can be used in crowds to do this, and you mentioned the study. Could I quote the study again as you're looking to do a reflection on it? Thank you in advance. Tyrell, the study was by Dr. Chris Cocking in 2013, and it was on the response of the public in the 7/7 London bombings. Off the top of my head, I can't give you the article citation, but I am sure that if you visit our website, promed999.co.uk, hover over training at the top, click on webinars, and then click on the slides from last week's webinar, the full citation in Harvard format, so a bit of copy and paste that into Google, it will find that paper. I believe it is a paid paper, so if you're at university or otherwise have academic library access, you'll be able to access it. If you don't, if you email me privately, webinars@promed999.co.uk, we may have a copy. So, yep, you're very welcome, everybody. That's all of the questions that I have gone through that I can see. So if anybody else does have any questions, now is your final opportunity to ask any questions. Feel free to raise your hand. I'd love to hear somebody else's voice other than my own. Any questions at all, no matter how silly, crazy, convoluted, far-fetched, off on a tangent you think they are, more than willing to answer any of those questions or listen to anybody with them. Okay, you've got until we get the next slides out the way then. So speak now or forever hold your peace. Once again, just to remind you, if you want a CPD certificate, all you need to do is email webinars@promed999.co.uk with the full name that you'd like on your certificate. And if your email address or name is different to how you've appeared on Zoom tonight, please make sure that you provide the correct one for us to verify. We do pull the registration report from Zoom to verify that you were here. And digital certificates will be emailed to you within 3 business days. So that is the end of Tuesday at the latest, assuming that you email us tonight. We're really pleased that you've all been enjoying this tonight. In return for listening to our free of charge, highly knowledgeable, skilled and professional services, we would ask that you leave us at least 1 review. If you did leave us a review last week, that is us asking you to leave us another review this week, preferably on a different platform. I'm sure many of you have had the emails from Trustpilot asking you to click the stars that you want to rate us and type a sentence. That's quick and easy to do. You've also got yell.com if you use the link that's going in the chat. Google, again, link that's in the chat. And if you're already liked us on Facebook, you can review us on Facebook. We only have to a quick sentence. And it just helps us get our name out there as a reputable provider of these webinars and, of course, of our other services, the training that we provide. Of course, the other thing that we're going to add is that we are always on the lookout for high quality staff across the UK. So if you have attended one of our webinars and you think that you would like to earn some extra money working on our events that we have across the country, please do email apply@promed999.co.uk. Mention that you've attended these webinars. Obviously, we will be verifying that. But if you have attended these webinars and you send in your application form correctly, we will guarantee you a video interview. And assuming you pass that and you have your qualifications and your references come back clean and your DBS has nothing to declare, then we'll add you straight onto our bank staff because we know that you are committed to doing your CPD. We know that you are professionals and want to stay on top of your game. And that is exactly the ethos that we have at ProMed. This week, we did accredit ourselves as a living wage provider. So that was an external check of how we're paying our staff. So I can tell you now that those staff who are working for us guaranteeably get paid the real living wage, which is a minimum of £11.75 outside of London. And from memory, I think it is £13.50 inside of London. So we know we are paying very good rates to our staff. Last opportunity for any questions. Otherwise, I am going to mute myself and turn my video off and be quiet and let you guys go. I will be leaving the chat visible on screen and we won't be ending the meeting for about another 5 or 10 minutes. So if there are any links that you want to make a note of, or if anybody shared any of their social media details and you want to kind of keep in touch with them, we'll give you 5 or 10 minutes to gather anything you want from the chat in order to do that. The recruitment email, Patrick, is apply, APPLY, @promed999.co.uk. Okay, thank you very much for listening and a good night.